Welcome. In this session, we'll discuss central retinal vein occlusion, and in the next session, we'll take up branch retinal vein occlusion. In this session, we'll also discuss briefly about the variants of central retinal vein occlusion, namely hemicentral retinal vein occlusion and papillophlebitis. Venous occlusive disease of the retina is the second most common retinal vascular disorder after diabetic retinopathy, and branch retinal vein occlusion is more common than central retinal vein occlusion. Central retinal vein occlusion, or CRVO, is a cause of significant ocular morbidity, and in some studies CRVO has also been associated with increased mortality. CRVO usually occurs in individuals above 65 years of age in whom diabetes and hypertension are likely to coexist. CRVO-like presentation in younger patients is more likely to occur due to underlying hypercoagulable and inflammatory diseases, which we'll discuss. These two clinical photographs show the fundus of eyes with CRVO. This is a severe variant of CRVO, and this is a less severe variant of CRVO. CRVO is said to occur from a thrombus occluding the lumen of the retrolaminar portion of the central retinal vein. In this region within the optic nerve, the central retinal artery and the central retinal vein lie parallel to each other in a common adventitial sheath. When passing through the lamina cribrosa, these two vessels are compressed in the caves of the lamina cribrosa. In this region just posterior to the lamina, collateral vessels arise from the central retinal vein, pass through the lamina cribrosa and drain into the choroid. Factors which promote thrombus formation within the central retinal vein include increased blood viscosity, reduced blood flow velocity, endothelial disruption and inflammation of the central retinal vein, thickening of the central retinal artery, and posterior bowing of the lamina cribrosa. Posterior bowing of lamina cribrosa is found in glaucoma, and we'll find that glaucoma is a risk factor for CRVO. Obstruction of blood flow from the retina leads to retinal hemorrhage and ischemia. Less hemorrhagic or ischemic CRVO is said to occur from thrombus situated more posteriorly within the central retinal vein, because with a posteriorly situated thrombus, a larger number of collaterals will be on the retinal side of the thrombus, allowing drainage of blood from the retina. Secretion of vascular endothelial growth factor from ischemic retina promotes capillary leakage and neovascularization, and while capillary leakage can lead to retinal edema, neovascularization can lead to neovascular glaucoma, vitreous hemorrhage and retinal detachment. In addition to vascular endothelial growth factor, other pro-inflammatory factors are also released by hypoxic retina, which contribute to vessel damage and retinal edema, and so steroids, in addition to anti-VEGF, can be used to treat macular edema from CRVO. The most common site of neovascularization in CRVO is the anterior segment on the iris and in the angle, followed by retina and the optic disc, and this is very important to remember. Hemicentral retinal vein occlusion, also known as HCRVO or HRVO, may occur in eyes where the two tributaries of the central retinal vein unite behind the lamina cribrosa to form the central retinal vein. This anatomy occurs normally in 20% of eyes, and HCRVO occurs in these eyes when one of the two tributaries is occluded by a thrombus behind the lamina cribrosa. As a result, HCRVO affects either the superior or the inferior half of the retina instead of all four quadrants, which is found in CRVO. HCRVO behaves more like CRVO than like BRVO in terms of risk of neovascularization, response to treatment, and visual outcomes, and this is important to remember. Papillophlebitis is considered as a milder variant of CRVO occurring in patients younger than 50 years of age, and the cause of papillophlebitis is said to be an inflammatory neuropathy or vasculopathy. Patients with papillophlebitis present with mild visual difficulties and or transient visual obscurations. Optic disc edema is the major finding in papillophlebitis, with associated peripapillary retinal hemorrhages and cotton wool spots as seen here in this clinical photograph. And it has been found that 30% of patients with papillophlebitis may progress to ischemic CRVO. Risk factors predisposing to CRVO can be systemic or ocular. Systemic risk factors include vascular diseases and their risk factors such as increasing age, systemic arterial hypertension, diabetes mellitus, hyperlipidemia, smoking, arteriosclerosis, and hypothyroidism. And these three are very important to remember. Hematologic abnormalities such as hypercoagulable states and hyperviscosity syndromes may also cause CRVO, and these etiologies are more likely in CRVO patients less than 60 years of age. Patients with CRVO due to these abnormalities commonly present with bilateral CRVO, and these etiologies may also cause combined retinal arterial and venous occlusions, also called mixed occlusions, as seen in this clinical photograph, where we find whitish retina in the territory of inferotemporal artery along with dilatation of all retinal veins signifying associated CRVO. And in these patients, treatment of the underlying etiology may reverse the course of retinopathy. So patients with bilateral or mixed occlusions should be screened for hematologic abnormalities, and this is very important to remember. CRVO due to inflammatory involvement of the central retinal vein is also more common in younger individuals and can occur from multiple inflammatory etiologies, and drugs and interventions such as diuretics, oral contraceptives, and retrobulbar block can increase the risk of CRVO, and Valsalva maneuver and pregnancy has also been associated with increased risk of CRVO. Ocular risk factors of CRVO include glaucoma, which is very important to remember, and we may note here that glaucoma can increase the incidence of CRVO, and CRVO in turn can cause glaucoma, chiefly neovascular glaucoma. CRVO can also occur from other causes of compression on the optic nerve, and causes of internal compression of the optic nerve include acute ischemic optic neuropathy, papilledema, and optic disc drusen, and external causes of compression of the optic nerve include thyroid ophthalmopathy, retrobulbar tumors, and orbital fractures. Patients with CRVO usually present with sudden onset painless loss of vision, and the loss of vision can be due to macular ischemia, foveal hemorrhage, and macular edema and or exudates, and this is very important to remember. As we will discuss, retinal hemorrhage disappears with time. Macular edema responds to treatment with anti-VEGF and or steroids, but macular ischemia is untreatable, and some patients may have episodes of transient obscuration of vision prior to persistent decline in vision and appearance of retinal manifestations. CRVO is usually unilateral, and it has been estimated that only 10% of patients with unilateral CRVO develop CRVO in the fellow eye within 5 years of CRVO occurring in the first eye. As seen in these two clinical photographs, the classic signs of central retinal vein occlusion are intraretinal hemorrhages, both dot blot and flame shaped, and dilated and tortuous retinal venous system in all four quadrants. Presence of these two clinical features in all four quadrants help us to differentiate central retinal vein occlusion from hemicentral retinal vein occlusion and branch retinal vein occlusion. The central vein occlusion study, which we will be discussing further, classified CRVO based on perfusion status on fluorescent angiography in 7 standard ETDRS photographs. Perfused or non-ischemic CRVO has less than 10 disc areas of retinal capillary non-perfusion, as seen here in this angiogram. This is blocked fluorescence corresponding to the hemorrhage clinically visible here. Eyes with non-perfused or ischemic CRVO has 10 or more disc areas of retinal capillary non-perfusion, as seen here in this angiogram. And eyes labeled as indeterminate usually has significant intraretinal hemorrhages causing blocked fluorescence, precluding assessment of capillary perfusion, and so also precluding classification into these two types. And the CVOS found that majority of eyes in the indeterminate group at baseline had ischemic CRVO on follow-up, when reduction or disappearance of retinal hemorrhage made assessment of retinal capillary perfusion on fluorescent angiography possible. In addition to fluorescent angiography, which was used by CVOS to classify CRVO into ischemic and non-ischemic types, other clinical and diagnostic characteristics can also help us to differentiate between ischemic and non-ischemic CRVO. And these characteristics, which are typically found in eyes with ischemic CRVO in contrast to eyes with non-ischemic CRVO, are poorer baseline visual acuity, relative afferent pupillary defect, greater degree of intraretinal hemorrhages at baseline, negative ERG waveform indicating dysfunction of the inner retina, and dense central scotoma and or marked peripheral constriction on visual field testing. And these are very important criteria to remember. And as we will be discussing further, eyes with significant ischemia or non-perfusion have more severe macular edema, are more likely to develop anterior segment neovascularization, and have a poorer final visual acuity. Macular edema is very common in CRVO, and it is the most common cause of vision loss in CRVO. It is found in almost all patients with ischemic CRVO and in many patients with non-ischemic CRVO. Other signs of CRVO include cotton wool spots, hard exudates, optic nerve swelling, and breakthrough vitreous hemorrhage, and these signs are more severe and more extensive in eyes with ischemic CRVO. Occasionally, a ciliretinal artery occlusion may occur in an eye with CRVO. The artery is present in 15 to 30% of individuals in the population, and this artery originates from the low pressure posterior ciliary circulation and drains into the retinal venous system. So in an eye with CRVO which has a ciliretinal artery, the ciliretinal artery may be occluded due to the high intraluminal pressure of the retinal venous system into which the ciliretinal artery drains. Rarely CRAO can also occur due to similar reasons, but CRAO in an eye with CRVO is more commonly due to underlying hematologic abnormalities, as we have discussed. This red-free photograph shows an eye with CRVO having ciliretinal artery occlusion causing whitening of this portion of the retina, and fluorescent angiography in this eye showed delayed filling of the ciliretinal artery and non-perfusion of the retinal capillaries in the area of retinal whitening. Over time, hemorrhages decrease and may disappear, but macular edema usually persists without treatment. CRVO eyes, initially found to be non-ischemic at baseline, may become ischemic over time, and neovascularization can develop over time in eyes either ischemic at baseline or becoming ischemic over time. This photograph shows an eye with iris neovascularization and the ectropy on UV, which is characteristic of eyes with iris neovascularization. Macular edema and neovascularization developing in eyes with CRVO are indications for treatment, as we will be discussing, and conversion of non-ischemic CRVO to ischemic CRVO is very important to remember, which we will be discussing further. Over time, epiretinal membrane formation, foveal pigmentary changes, and macular atrophy can also occur in eyes with CRVO, and optociliary shunt vessels or collaterals, as seen here in this clinical photograph, may develop on the optic disc, and the optic disc may become pale. The optociliary shunt vessels are dilated shunt vessels draining blood from the retinal vein to the choroidal circulation, and the optociliary shunt vessels are indicators of previous episode of CRVO following complete disappearance of intraretinal hemorrhages. The most common location of neovascularization in CRVO is the anterior segment, and the incidence of anterior segment neovascularization peaks at 2 months but can occur at any time between 2 weeks to 6 months. Iris neovascularization, as seen here in this clinical photograph, usually starts at the pupillary border and then progresses to involve the entire iris surface. Angle neovascularization appears as fine blood vessels crossing anteriorly over the scleral spur on gonioscopic examination, as seen here in this gonioscopic photograph. Angle neovascularization may lead to peripheral anterior synechia and neovascular glaucoma. And since neovascular glaucoma induced by CRVO is commonly found at the end of 3 months following the onset of CRVO, this glaucoma is also called 90-day glaucoma. And it is important to note that Neovascularization of the angle may be present in the absence of neovascularization of the iris, indicating the need of gonioscopy during examination of a CRVO patient, and so undilated slit lamp examination to detect iris neovascularization and undilated gonioscopy to detect angle neovascularization is recommended at every follow-up visit in eyes with CRVO, and this is very important to remember. Neovascularization can also occur on the optic disc and on the retina in CRVO. And unlike optociliary shunt vessels, NVD appears much finer in caliber, forms a network, and leak fluorescent profusely. NVD and NVE may lead to vitreous hemorrhage and tractional retinal detachment. So when examining a patient with CRVO, we should take a history of duration of visual loss, presence of systemic vascular diseases such as hypertension, diabetes, and coronary artery disease, and personal or family history of hypercoagulable disorders, particularly in younger patients with CRVO without a history of systemic vascular diseases. And examination required at presentation and at every follow-up visit include visual acuity, pupillary reactions, undilated slit lamp examination to detect iris neovascularization, undilated gonioscopy to detect angle neovascularization, and intraocular pressure, following which the pupil should be dilated for ophthalmoscopy. Fluorescent angiography in CRVO patients show delayed filling of retinal veins, blocked fluorescence from hemorrhages, and capillary non-perfusion as shown here in this angiogram, both in the macula and the periphery, which becomes more readily identifiable when hemorrhages decrease. Fluorescent angiography in CRVO can also show macular edema, neovascularization, and optociliary shunt vessels. As we have mentioned, neovascularization either on the disc or on the retina demonstrate profuse leakage of fluorescence, which optociliary shunt vessels don't. OCT in CRVO almost always shows macular edema, as seen here in this OCT photograph, with retinal thickening, cystoid spaces, and subretinal fluid. Paracentral acute middle maculopathy or PAMM can be found in eyes with CRVO, indicating macular ischemia. We have discussed about PAMM in the session on hypertensive retinopathy, and PAMM is an OCT feature of hyperreflectivity of the middle retinal layers occurring due to ischemia of the inner nuclear layer following occlusion of the deep retinal capillary plexus. This OCT photograph shows extensive areas of hyperreflectivity of the inner retinal layers with sparing of the outer retinal layers, and this occurs because the inner retinal layers are supplied by the retinal circulation while the outer retinal layers are supplied by the choroidal circulation. Disorganization of retinal inner layers, also called DRIL, and ellipsoid zone disruption at baseline indicate poor visual prognosis. We have discussed about DRIL in the session on non-proliferative diabetic retinopathy, and DRIL refers to the inability to identify the retinal layers lying between the ganglion cell layer and the inner plexiform layer separately in the central 1 mm of the retina on OCT-B scan. Ellipsoid zone disruption indicates photoreceptor dysfunction and refers to discontinuity of the ellipsoid zone line on OCT-B scan, which lies close to the junction between the inner and the outer segments of the photoreceptors. In eyes with CRVO, octa may show areas of enlargement of foveal avascular zone, capillary dilatation, and non-perfusion. And non-perfusion on octa appears to be more prominent in deep retinal capillary plexus, correlating with the extent of paracentral acute middle maculopathy on OCT. This is said to be because the major venous outflow of retina is from the deep retinal capillary plexus, and in the acute phase of CRVO, artifacts may appear on octa due to edema, hemorrhage, and suspended particles in motion, which occurs within cystoid spaces in the retina. Systemic workup is not required in patients older than 60 years of age with associated systemic vascular diseases, and this is important to remember. But systemic workup is indicated in younger patients who do not have associated systemic vascular diseases, particularly patients who have bilateral simultaneous CRVO, previous history of vascular occlusion in the fellow eye, mixed type vascular occlusion involving both arteries and veins, history or family history of thrombotic diseases, and evidence of worsening perfusion over time. And systemic workup should be done with co-consultation with hematologist and or rheumatologist. We should include physical examination and lab investigations. Physical examination must include examination of blood pressure, and lab investigation should include testing for lipid profile and plasma glucose, with these three tests enabling us to identify undetected systemic vascular diseases, and also complete blood counts, blood chemistry profile and coagulation profile. In patients with abnormal coagulation profile, coagulation factors and serum protein electrophoresis are among the tests which should be ordered, and in patients with blood count suggesting inflammation, workup is indicated for inflammatory diseases. The most important differential diagnosis of CRVO is ocular ischemic syndrome, which occurs due to obstruction at the level of the carotid arteries, and ocular ischemic syndrome can be differentiated from CRVO by retinal hemorrhages being restricted to the deeper retina and so being only dot blot in shape, and also being restricted to mid-peripheral retina as seen here in this clinical photograph, instead of also involving the posterior pole and the periphery. Another characteristic of ocular ischemic syndrome is the absence of retinal venous tortuosity, and in ocular ischemic syndrome, the retinal arteries appear narrow and beaded, and the retinal veins appear dilated and beaded but not tortuous. Low IOP can occur in eyes with ocular ischemic syndrome due to ciliary body ischemia, and since the obstruction in ocular ischemic syndrome is proximal to the ophthalmic artery, choroidal ischemia may also occur in eyes with ocular ischemic syndrome. Other differentials of CRVO include diabetic retinopathy, hypertensive retinopathy, particularly the malignant variety, radiation retinopathy, and severe anemia with thrombocytopenia. And since diabetes and hypertension are risk factors for CRVO, diabetic retinopathy and hypertensive retinopathy may coexist with CRVO, but these entities may be difficult to differentiate from each other. The Central Vein Occlusion Study, or CVOS, was a landmark prospective study on CRVO, and it included 728 eyes with CRVO which were followed up 4-monthly for 3 years. It should be noted that CVOS was conducted prior to anti-VEGFs became available for treatment of macular edema. The CVOS found that the final visual acuity depended to a large extent on visual acuity at presentation, with almost 1/3 of patients presenting with either good visual acuity of 20/40 or better, or a poor visual acuity worse than 20/200, and the remainder, a little more than 1/3 of all the patients, presented with an intermediate visual acuity between 20/40 and 20/200. Among the patients who presented with a good visual acuity, the majority, or 65%, retained their visual acuity of 20/40 or better at final follow-up. And among the patients presenting with a poor visual acuity, the majority, or 80%, retained visual acuity in the same range of worse than 20/200 at final follow-up. And among the patients presenting with an intermediate visual acuity, almost half retained visual acuity between 20/40 and 20/200. A little over 1/3 of patients had visual acuity deterioration to worse than 20/200, and only 1/5 of patients had visual acuity improvement to better than 20/40 at final follow-up. At baseline, 75% of eyes included in CVOS were found to be perfused or non-ischemic on fluorescein angiography, but on follow-up, 34% of these eyes which were perfused at baseline converted to non-perfused status within 3 years, with 15% converting to non-perfused status within first 4 months. And these two figures are very important to remember. So this figure is significant because it indicates that even eyes perfused or non-ischemic at baseline should be followed up. And CVOS found that 16% of total patients developed iris or angle neovascularization, with the most important risk factors for neovascularization identified by CVOS being baseline visual acuity and extent of non-perfusion, which is also important to remember. So compared to 16% of total patients in CVOS developing neovascularization, 10% of eyes initially perfused and 35% of eyes initially non-perfused or having indeterminate perfusion developed neovascularization, and whereas only 5% of eyes with initially good visual acuity developed neovascularization, more than 30% of patients with poor visual acuity developed neovascularization on follow-up. The CVOS concluded that visual acuity at presentation is a strong predictor of final visual acuity in patients presenting with good vision that is better than 20/40, and also in patients presenting with poor vision that is worse than 20/200. But in patients with intermediate visual acuity at presentation, that is between 20/40 and 20/200, visual acuity at presentation was a poor predictor of final visual acuity, that 1/3 of initially perfused eyes developed non-perfusion over 3 years, and that visual acuity and perfusion status at presentation were the strongest predictors of neovascularization. Management of CRVO involves systemic intervention and ocular intervention. Systemic intervention includes control of hypertension, diabetes, and hyperlipidemia if present, and in this group of patients, systemic anticoagulation has been found to be of no benefit and may actually result in increased retinal hemorrhage. But if the patient is found to be having hypercoagulable, hyperviscosity, and inflammatory disorders, treatment of these disorders are indicated, and treatment of these disorders may actually result in reversal of the progression of CRVO. We will be discussing about the ocular interventions in more detail, and ocular interventions include pan-retinal photocoagulation for neovascularization, anti-VEGF injections for macular edema, and as a temporizing measure for neovascularization before definitive PRP for neovascularization, intravitreal steroids for macular edema, and treatment of neovascular glaucoma. It is important to note that pan-retinal photocoagulation is the definitive treatment for neovascularization, and although anti-VEGF injections cause regression of neovascularization, anti-VEGF injections are not considered as a definitive treatment for neovascularization, and intravitreal steroids are not indicated for neovascularization. Group M report of CVOS showed that grid laser therapy for CRVO-induced macular edema is of no clinical benefit, and it should be remembered that CVOS was conducted in the pre-anti-VEGF era. In this study, eyes with CRVO having angiographic macular edema were randomized to grid treatment or observation and followed up for 3 years, and this study found there was no difference in visual acuity between treated and untreated eyes at any time point during follow-up, but grid laser treatment did decrease angiographic macular edema, and the explanation for no difference in visual acuity in the CVOS study was the associated macular ischemia in these patients. It is important to note here that in contrast to CRVO, grid laser is recommended for macular edema induced by BRVO. Neovascularization of the iris extending for 2 clock hours, abbreviated as TCNVI, and neovascularization of the angle, abbreviated as NVA, were important parameters in the CVOS study, and the Group N report of the CVOS showed that pan-retinal photocoagulation does not totally prevent TCNVI and or NVA, but causes more prompt regression of NVI and or NVA developing in previously untreated eyes as compared to previously treated eyes. In this study, eyes with ischemic CRVO were randomized to immediate prophylactic PRP with the intention to prevent development of neovascularization and to an observation group, and patients in both the groups received frequent follow-up. And if TCNVI and or NVA developed during follow-up, untreated patients received pan-retinal photocoagulation, and eyes which have already received prophylactic PRP received supplemental PRP. And the study found that the difference in the incidence of TCNVI and or NVA was not significant between the two groups, although it occurred less often in eyes undergoing prophylactic PRP. But following development of TCNVI and or NVA during follow-up, PRP induced prompt regression of TCNVI-NVA within 1 month in significantly more previously untreated eyes as compared to eyes which received supplemental PRP after initial prophylactic PRP. So CVOS recommended careful follow-up of eyes with ischemic CRVO without neovascularization at presentation, and performing PRP only when 2 clock hour NVI and or NVA develop on follow-up, and prophylactic panretinal photocoagulation at baseline to prevent development of NVI and or NVA was not recommended, and this is very important to remember. And of course, patients presenting with or developing NVD or NVE with or without NVI and or NVA should also be treated with panretinal photocoagulation. Intravitreal steroids are used to treat macular edema induced by CRVO, and the proposed mechanisms of action include stabilization of the blood-retina barrier and reduced production of cytokines including VEGF. But intravitreal steroids are associated with well-known side effects of raised intraocular pressure and cataract progression. The SCORE trial was a landmark trial in the management of CRVO and compared the safety and efficacy of two doses, namely 1 mg and 4 mg of triamcinolone versus observation for treatment of macular edema in eyes with perfused CRVO. A total of 271 eyes were randomized to three groups, one receiving 1 mg triamcinolone, the second receiving 4 mg triamcinolone, and the eyes in the third group being observed. Eyes in the triamcinolone groups received triamcinolone injections at baseline, and the triamcinolone injections were repeated every 4 months in the absence of significant improvement in visual acuity and absence of significant adverse effects. The SCORE trial concluded that both 1 mg and 4 mg triamcinolone was superior as regards gain in visual acuity as compared to observation, and also that 1 mg and 4 mg were equally efficacious as regards gain in visual acuity, but incidence of adverse effects, namely cataract and elevated intraocular pressure, were lower in the 1 mg triamcinolone group as compared to that in the 4 mg triamcinolone group. This chart shows the 6-month results from baseline in the SCORE trial. Now there are quite a few studies which evaluated the efficacy of intravitreal drugs in the management of macular edema due to retinal vein occlusion without differentiating between CRVO and BRVO. And one of them was the GENEVA study, which compared the safety and efficacy of single administration of 2 doses of intravitreal dexamethasone implant 0.7 mg and 0.35 mg against sham in eyes with central or branch retinal vein occlusion with vision loss due to macular edema. The GENEVA study included a total of 1267 patients, and among the 136 eyes with CRVO, the study found that at 6 months, the percentage of patients gaining 15 or more letters were significantly higher than sham-treated eyes in the 0.7 mg dexamethasone implant group at 30 and 60 days, but not at 90 and 180 days, and also in the 0.35 mg group at 30, 60 and 90 days, but not at 180 days. The incidence of cataract surgery was similar with the 2 doses of dexamethasone, and 30% of dexamethasone treated patients required ocular hypotensives. The study was extended and all patients received repeat treatment with dexamethasone 0.7 mg at day 180 following the first injection, and at 12 months the visual acuity results were found to be similar to that at month 6, and 36% of patients in 0.7 mg dexamethasone group required ocular hypotensives. A smaller uncontrolled trial also evaluated the efficacy of sustained release fluocinolone implant in CRVO associated macular edema, and this trial reported the mean visual acuity gains, the proportion of patients gaining 10 or more letters, and the reduction of central foveal thickness at the end of 1, 2 and 3 years following injection of the fluocinolone implant. Over 3 years, the study observed that all phakic eyes ultimately had to undergo cataract surgery, and 33% of eyes underwent glaucoma surgery, and another 38% required ocular hypotensives. Anti-VEGFs have been extensively studied for the management of macular edema induced by CRVO, and intravitreal ranibizumab, aflibercept and faricimab have been approved by FDA in the management of CRVO-induced macular edema. Also, intravitreal anti-VEGFs induced rapid regression of anterior segment neovascularization, but since the duration of action of a single injection of anti-VEGF is much shorter than the duration of action of panretinal photocoagulation is still the definitive treatment for anterior segment neovascularization, as we have discussed. And we note here that for anterior segment neovascularization, anti-VEGFs are injected intravitreally. Brolucizumab has not been approved by FDA for the management of macular edema induced by CRVO because of increased incidence of intraocular inflammation in the phase 3 trials of this drug. And bevacizumab is not FDA approved for intraocular use for any indication, but is widely used in clinical practice because of its lower cost per patient. CRUISE was a phase 3 trial designed to evaluate the safety and efficacy of two doses of ranibizumab, 0.3 mg and 0.5 mg versus sham in macular edema due to CRVO. 392 patients were included and were randomized to three groups receiving monthly injections of 0.3 mg ranibizumab, 0.5 mg ranibizumab or sham. At 6 months, the study concluded that both 0.3 mg and 0.5 mg ranibizumab provided rapid improvement of visual acuity and reduction of macular edema with low rates of ocular and non-ocular adverse effects. This table shows the 6-month results of the CRUISE trial. After 6 months, all patients with BCVA 20/40 or worse and central foveal thickness 250 micron or more received ranibizumab, and at 12 months, the study concluded that patients in the original ranibizumab groups in the first 6 months on average retained their visual acuity and anatomic gains which were achieved at 6 months from baseline, whereas patients in the original sham group in the first 6 months treated with ranibizumab as required in the next 6 months had rapid reduction in central foveal thickness similar to the other two groups which received the 2 doses of ranibizumab in the first 6 months and also gained visual acuity, but the gain in visual acuity was not to the same extent as the other two groups, and this implies that early initiation of treatment for macular edema induced by CRVO is recommended. Early initiation of treatment of macular edema due to CRVO results in better functional outcomes in the long term as compared to delayed initiation of treatment. This chart shows the 12-month results from the CRUISE trial. The Horizon trial was a 12-month extension trial of patients who were originally in the CRUISE and BRAVO studies. The BRAVO study evaluated the efficacy of ranibizumab in macular edema due to branch retinal vein occlusion. We should note here that there is another Horizon trial arm, which was a 12-month extension trial of patients originally in the Retina and the Anchor trials, which evaluated the efficacy of ranibizumab in the treatment of choroidal neovascularization in neovascular AMD. In the Horizon extension trial, patients were followed up every 3 months and given 0.5 mg ranibizumab if they met pre-specified criteria, and at 24 months the Horizon trial found that patients who were originally in the CRUISE study had decline of visual acuity, while patients who were originally in the BRAVO study remained stable when visual acuity at 24 months was compared with the visual acuity at the end of 12 months of the original CRUISE and BRAVO study. Also, proportion of patients from the CRUISE study who had a gain of 15 or more letters from baseline declined as compared to the proportion gaining 15 or more letters at the end of initial 12 months of the CRUISE study. The Horizon study concluded that CRVO eyes required closer follow-up long term, and the data shows that the mean change of visual acuity in the second year was worse in CRVO eyes in CRUISE trial as compared to BRVO eyes in the BRAVO trial. The Retina was a 2-year extension trial of patients who completed the Horizon trial and included 32 CRVO eyes and 34 BRVO eyes. The patients were examined monthly in the 3rd year and at least every 3 months in the 4th year, and intravitreal 0.5 mg ranibizumab was administered according to pre-specified criteria. So in the 3rd year, patients in the Retina study had a closer follow-up and more frequent injections than in the Horizon study. And at the end of 49 months from baseline, the Retina study concluded that long-term outcomes in the BRVO group were excellent, and a substantial but minority of patients in the CRVO group had good visual outcomes. And this table shows the data from the Retina study. The Crystal was a non-randomized prospective trial evaluating the safety and efficacy of ranibizumab in the treatment of macular edema due to CRVO. In this trial, 357 patients were administered ranibizumab 0.5 mg monthly injections for 3 months, followed by monthly follow-up, and ranibizumab 0.5 mg PRN based on visual acuity criteria. And at 12 months, the study found that visual acuity gains were better in patients with shorter pre-treatment duration of symptoms as compared to patients with longer pre-treatment duration of symptoms, which also indicates that early treatment of macular edema due to CRVO is imperative. Copernicus and Galileo were two similarly designed phase 3 trials to evaluate the safety and efficacy of aflibercept in macular edema due to CRVO. Patients were randomized to receive either intravitreal 2 mg aflibercept or sham injections every month for 6 months. At 6 months, both Galileo and Copernicus observed significant improvement of visual acuity, reduction in central retinal thickness, and in the Copernicus study, prevention of neovascularization with aflibercept. This table shows the 6-month data of Copernicus and Galileo trials. So none of the patients with aflibercept developed neovascularization in the Copernicus trial, but 6.8% of patients receiving sham injections developed neovascularization. From 6 months onwards, all patients both in the initial aflibercept group and in the initial sham group in the Copernicus trial were followed up every 4 weeks and received aflibercept as required based on pre-specified criteria, whereas in the Galileo trial, patients in the initial aflibercept group were followed up every 4 weeks and received aflibercept as required, and sham patients continued to receive sham injections. At 12 months, both trials concluded that patients receiving monthly aflibercept injections in the first 6 months and then PRN injections of aflibercept maintained visual gains which were achieved at the end of 6 months. Patients receiving aflibercept monthly in the first 6 months and then aflibercept PRN in both the trials had significant improvement in functional results as compared to patients receiving sham followed by aflibercept injections in the Copernicus trial, and also patients who received only sham injections in the Galileo trial, thus implying again that early initiation of treatment of macular edema in CRVO is imperative. From 12 months onwards, all patients in both the trials were followed up and received aflibercept as needed based on pre-specified criteria. And the Copernicus trial, which was concluded after 24 months, found that anatomical and functional gains which were achieved at the end of the initial 12 months declined with reduced monitoring frequency. And the Galileo trial, which was concluded after 18 months, found that anatomical and functional gains which were achieved at the end of 12 months since initiation of the trial were largely maintained, and patients receiving aflibercept early on benefited. This table shows the data from the end of the Copernicus trial at 24 months and the end of the Galileo trial at 18 months. Epstein et al. Compared the efficacy of bevacizumab, a low-cost anti-VEGF, versus sham in CRVO-induced macular edema. Patients were randomized to bevacizumab and sham groups, each receiving injections every 6 weeks. A total of 60 patients were included, and at 6 months, the study concluded that patients receiving bevacizumab injections had improved visual acuity and reduced macular edema as compared to patients in the sham group. This table shows the 6-month results from baseline in this trial. After 6 months, all patients in both groups received bevacizumab injections every 6 weeks, and at 12 months, the study concluded that patients receiving delayed intraocular bevacizumab had limited visual acuity improvement, particularly those above 70 years of age. So those receiving bevacizumab since baseline fared much better than those receiving bevacizumab in the second 6 months, although the mean change in central retinal thickness was almost comparable. The SCORE2 was an important trial comparing the efficacy of bevacizumab versus aflibercept in the treatment of macular edema secondary to CRVO or HCRVO. 362 patients were randomized to receive 4 weekly injections of either 1.25 mg bevacizumab or 2 mg aflibercept for 6 months. At 6 months, the SCORE2 concluded that visual acuity gains with bevacizumab was non-inferior to aflibercept, with the non-inferiority criteria set at 5 letters in the treatment of macular edema secondary to CRVO and HCRVO. But patients receiving aflibercept had a greater reduction of macular edema compared to those receiving bevacizumab. This table shows the 6-month results from baseline in the SCORE 2 trial, with the functional results being almost similar in the two groups, but the anatomical results being better in the aflibercept group. At 6 months following the initiation of the SCORE 2 trial, poor responders were segregated from good responders, with poor responders being classified as those having visual acuity of fewer than 58 letters on the ETDRS chart, or improvement of fewer than 5 letters from baseline in the ETDRS chart, or a central subfoveal thickness of 300 micron or more, or presence of intraretinal cysts and subretinal fluid on OCT. It was found that in the original bevacizumab group, 77.5% were good responders, and in the original aflibercept group, 91.4% were good responders. The good responders at 6 months were randomized to receive either monthly injections of their original drug or to receive treat and extend regimen of their original drug, the original drug being either aflibercept or bevacizumab. And the study found that from month 6 to month 12 in good responders, the mean visual acuity difference between these two groups were similar in those receiving bevacizumab as compared to those receiving aflibercept, and the mean number of injections given in the treat and extend regimen were 4.5 in the bevacizumab group and 3.8 in the aflibercept group. The poor responders in the original bevacizumab group at the end of initial 6 months received aflibercept injections at 6, 7 and 8 months, and then aflibercept in a treat and extend regimen, and poor responders in the original aflibercept group at the end of the initial 6 months received dexamethasone implant at month 6 and then if needed at month 9, 10 or 11. At 12 months, the study concluded that among the poor responders, the mean change in visual acuity from month 6 to month 12 were significantly higher in those who were shifted from bevacizumab in the first 6 months to aflibercept in the second 6 months as compared to those who were shifted from aflibercept in the initial 6 months to dexamethasone in the next 6 months. And the mean change in central subfoveal thickness from month 6 to month 12 matched the mean change in visual acuity, with the bevacizumab aflibercept group having further reduction in macular edema, whereas the aflibercept dexamethasone group had actually an increase in macular edema. So at the end of 12 months, the SCORE 2 study concluded that among good responders, 1 to 2 fewer injections were required in the treat and extend regimen as compared to monthly regimens in both the bevacizumab and aflibercept groups, and the differences in visual acuity results between the two regimens, that is monthly versus treat and extend, could not be concluded because of wide confidence intervals. And among poor responders at the end of the initial 6 months, eyes switched to aflibercept because of poor response to bevacizumab showed improvement in both visual acuity and central subfoveal thickness, and only a few eyes, that is 8% of eyes in the original aflibercept group, required switching to dexamethasone. After 12 months, there were no protocol-defined criteria in the SCORE 2 trial, and patients could be treated as decided by physician with any drug, either a study drug, that is bevacizumab or aflibercept, or any other drug. 236 eyes completed 24 months follow-up. At 24 months, SCORE 2 concluded that there was no difference in improvement of visual acuity or reduction of central subfoveal thickness between patients treated originally with bevacizumab or aflibercept, but there was decline in either parameter, visual acuity and central subfoveal thickness, in each group, that is bevacizumab and aflibercept, from month 12 to month 24, and so SCORE 2 recommended that CRVO and HCRVO patients require closer monitoring and treatment at least over 2 years. This table shows the 24-month results of the SCORE 2 trial, and although there was improvement since baseline in both visual and anatomic outcomes, there was actually a deterioration from month 12 to month 24 in both original bevacizumab and original aflibercept groups. SCORE 2 also compared the results of treatment between CRVO and HCRVO patients, and it found that patients with CRVO presented with worse visual acuity and macular edema at baseline as compared to patients with HCRVO, and at the end of 24 months from baseline, SCORE 2 found that anatomic and functional gains from baseline were similar in both CRVO and HCRVO eyes. The SCORE 2 trial was extended further, and from 2 years to 5 years, patients were treated at physician's discretion as in the second year, and 150 patients completed the 5 years of the study. And similar to the finding at the end of 2 years, at the end of 5 years, overall mean change in visual acuity from baseline at the end of 5 years declined as compared to mean change in visual acuity at 12 months from baseline, and there was no significant difference in this value between the original two groups receiving either aflibercept or bevacizumab, indicating need for closer monitoring of patients with CRVO and HCRVO long term. The LEAVO trial compared the efficacy of ranibizumab, bevacizumab and aflibercept in macular edema secondary to CRVO. 463 patients were randomized to the 3 drug groups and received a loading dose of monthly injections for 3 doses of their respective drug and were then followed up monthly till week 20, following which the follow-up intervals could be extended to 8 weeks, and during these follow-ups the patient could receive repeat injections of their respective drugs according to pre-specified criteria. And at the end of 100 weeks from baseline, the LEAVO study concluded that aflibercept was non-inferior to ranibizumab as regards visual acuity gains, but bevacizumab was not non-inferior to ranibizumab. So the visual acuity gains with ranibizumab and aflibercept were superior to those obtained with bevacizumab. The COMINO trial compared the safety and efficacy of intravitreal faricimab versus aflibercept for treatment of center-involved macular edema from CRVO and HCRVO. 729 patients with CRVO were randomized to receive either faricimab 6 mg or aflibercept 2 mg every 4 weeks for 24 weeks. At 24 weeks, the COMINO concluded that BCVA gains with faricimab was non-inferior to that achieved with aflibercept, and reduction in central subfoveal thickness achieved with faricimab and aflibercept were comparable. Also, greater proportion of patients receiving faricimab achieved absence of leakage on fluoresceint angiogram as compared to patients receiving aflibercept. This table shows the data of the 6-month results from baseline of the COMINO trial. COMRADE C compared the efficacy of ranibizumab and anti-VEGF versus dexamethasone implant, a steroid, in macular edema due to CRVO. 243 patients were included in the COMRADE C trial and were randomized to receive either ranibizumab monthly for 3 doses followed by ranibizumab PRN or a single administration of dexamethasone implant. At the end of 6 months, the COMRADE C trial reported that visual acuity results were similar at 1 and 3 months from baseline in both the ranibizumab and dexamethasone group, but ranibizumab group had better visual outcomes as compared to the dexamethasone group from 3 to 6 months since baseline, and also ocular adverse effects were more common in the dexamethasone group. So at 6 months from baseline, gain in visual acuity was more in the ranibizumab group than in the dexamethasone group. After the end of 6 months, patients in the COMRADE C trial were followed up monthly and received their respective treatment as required, and at the end of 12 months, the study reported that visual acuity results were better in the ranibizumab group as compared to the dexamethasone group, but the difference in the visual acuity gains were not significant. 5.3 to 7.8% of eyes receiving anti-VEGF therapy for macular edema due to CRVO developed neovascularization in the CRUISE, COPERNICUS and GALILEO trials. The CRUISE trial, however, excluded eyes with severe non-perfusion at baseline. De Cruz et al. Reported that the mean interval of neovascularization occurring after the last anti-VEGF injection in CRVO eyes being treated with bevacizumab or ranibizumab for macular edema was 6 months, and the majority of eyes in this study had ischemic CRVO at baseline. And in the RAVE trial, 50% of ischemic CRVO eyes being treated with ranibizumab developed neovascularization at a mean follow-up period of 24 months. And so, as we have mentioned, definitive treatment for neovascularization is still pan-retinal photocoagulation. So anti-VEGF therapy for CRVO-induced macular edema should be initiated as early as possible, should be continued till macular edema resolves, and any drug or regimen, either monthly treat and extend or PRN, have been found to be equally efficacious and should be selected based on cost and treatment burden, but close and long-term follow-up with injection administered as required has been shown to improve outcomes and is highly recommended. Pars plana vitrectomy in CRVO is indicated for non-clearing vitreous hemorrhage to clear the media, but more importantly to administer full pan-retinal photocoagulation. In macular edema following CRVO, vitrectomy with internal limiting membrane peeling has been shown to reduce retinal thickness, but visual gains following pars plana vitrectomy for both these indications are uncertain due to underlying macular ischemia. And following pars plana vitrectomy, the duration of action of intravitreally administered drugs are shortened, and this is important to remember. So if anti-VEGF drugs are required following vitrectomy, they may need to be given more frequently. Alternative treatments have been tried to reduce or bypass the obstruction in the central retinal vein itself, but these procedures have not been incorporated in routine clinical practice because of variable outcomes and the risk of significant side effects. So pan-retinal photocoagulation and intravitreal anti-VEGF and/or steroids remain the gold standard of treatment for complications arising from CRVO. And these alternative treatments include chorioretinal venous anastomosis, where a connection is created between a branched retinal vein and the choroidal circulation, administration of tissue plasminogen activator either systemically intravitreally or by retinal vein cannulation, and radial optic neurotomy to relieve pressure on the central retinal vein at the scleral outlet. CRVO patients should be followed up monthly for the initial 6 months and then at longer intervals in the absence of clinical features requiring treatment such as macular edema and neovascularization. But patients requiring treatment for these complications of CRVO should be followed up closely for an extended period of time. To recap the salient points, central retinal vein occlusion or CRVO occurs due to formation of a thrombus in the central retinal vein behind the lamina cribrosa. It is a cause of significant ocular morbidity. CRVO usually occurs in an older age group, and the common risk factors for CRVO are hypertension, diabetes mellitus, hyperlipidemia, and glaucoma. CRVO can also occur in younger individuals, but in this age group, CRVO is more commonly due to hematologic and inflammatory causes. CRVO is usually unilateral, but patients with underlying hematologic and inflammatory disorders can have bilateral CRVO. Retinal ischemia from CRVO leads to secretion of cytokines, chiefly VEGF, which promotes capillary leakage causing macular edema and neovascularization. Patients with CRVO present with sudden onset painless loss of vision, and causes of visual loss in CRVO are macular hemorrhage, macular ischemia, and macular edema. The major signs in an eye with CRVO include retinal hemorrhages and dilated and tortuous retinal veins in all 4 quadrants of the retina. In addition, cotton wool spots, hard exudates, and optic disc swelling can also be found. Macular edema is very common in eyes with CRVO. CRVO eyes with a ciliretinal artery can develop a ciliretinal artery occlusion. Later neovascularization and optociliary shunt vessels can develop. Neovascularization in CRVO occurs most commonly in the anterior segment and can cause neovascular glaucoma. Undilated slit lamp examination and gonioscopy should be done in eyes with CRVO at every follow-up visit. Central Vein Occlusion Study or CVOS classified CRVO based on fluorescent angiography as non-ischemic and ischemic. Some eyes may be non-classifiable at presentation due to extensive retinal hemorrhages. Other clinical signs which favor a diagnosis of ischemic CRVO are a poorer visual acuity, relative afferent pupillary defect, more extensive retinal hemorrhages, negative ERG waveform, and central scotoma and peripheral constriction on visual field testing. Eyes with ischemic CRVO develop more severe macular edema and are at a much higher risk of developing neovascularization. In addition to retinal capillary non-perfusion, fluorescent angiography can show delayed retinal venous filling, blocked fluorescence from hemorrhages, retinal capillary leakage, neovascularization and optociliary shunt vessels, OCT mesomacular edema, and paracentral acute middle maculopathy. OCTA typically shows capillary dilatation and non-perfusion more prominently in the deep retinal capillary plexus. Systemic workup includes blood glucose, blood pressure, and lipid profile testing. Workup for hematologic and inflammatory disorders is indicated in patients without systemic vascular diseases, particularly in younger patients, those with suggestive systemic symptoms of hematologic and inflammatory disorders, and in those with bilateral CRVO. In CVOS, 75% of patients were non-ischemic at baseline, among whom 34% converted to ischemic CRVO within 3 years. 16% of all patients with CRVO develop neovascularization in CVOS, and the risk of neovascularization as determined by CVOS was highest in patients with poor vision and extensive retinal capillary non-perfusion at baseline. Differential diagnosis of CRVO include ocular ischemic syndrome, hypertensive retinopathy, diabetic retinopathy, radiation retinopathy, and severe anemia with thrombocytopenia. Management of CRVO includes systemic and ocular interventions. Systemic intervention includes control of diabetes, hypertension, and hyperlipidemia, and treatment of underlying hematologic and inflammatory disorders. Ocular interventions include panretinal photocoagulation for neovascularization, for which panretinal photocoagulation is the definitive treatment, intravitreal anti-VEGF for macular edema and neovascularization, and in neovascularization, anti-VEGFs are used only as a temporizing measure. Intravitreal steroids for macular edema, treatment of neovascular glaucoma, and pars plana vitrectomy for non-clearing vitreous hemorrhage and recalcitrant macular edema. CVOS showed that grid laser treatment for macular edema secondary to CRVO is of no clinical benefit, and that PRP is recommended only when neovascularization is detected. CVOS did not recommend prophylactic PRP at baseline to prevent future development of neovascularization. SCORE and GENEVA trials showed the efficacy of triamcinolone and dexamethasone respectively in the treatment of macular edema secondary to CRVO. SCORE trial found that adverse effects were less frequent with 1 mg triamcinolone as compared to 4 mg triamcinolone, although visual acuity gains were similar with the two doses of triamcinolone. CRUISE, GALILEO, and COPERNICUS and COMINO trials showed the efficacy of ranibizumab, aflibercept, and faricimab respectively in the treatment of macular edema secondary to CRVO, following which these drugs have been approved for this indication. Brolucizumab has not been approved for this indication. Copernicus also showed that aflibercept may reduce the risk of future neovascularization. Most of these trials show that early administration of anti-VEGF following onset of CRVO is beneficial in eyes with macular edema. They also show that reduction in frequency of follow-up and treatment administration in the long term resulted in decline from the visual gains achieved in the initial phases of the studies, thus recommending closer follow-up of CRVO eyes long term. SCORE 2 trial compared bevacizumab and aflibercept and found that as regards visual acuity gains, bevacizumab was non-inferior to aflibercept in the management of CRVO-induced macular edema, but aflibercept resulted in greater reduction in macular edema, and that there was a higher proportion of poor responders in the bevacizumab group. The poor responders in bevacizumab group, however, responded satisfactorily when switched to aflibercept. SCORE 2 trial also showed that eyes with CRVO had worse baseline visual acuity as compared to HCRVO, but both CRVO and HCRVO showed similar gains in visual acuity from baseline following anti-VEGF treatment. The LEAVO study compared bevacizumab, ranibizumab, and aflibercept in the treatment of CRVO-induced macular edema and found that as regards visual acuity gains, aflibercept was non-inferior to ranibizumab, but bevacizumab was not non-inferior to ranibizumab. COMRADE C trial showed that visual acuity gains with monthly injections of ranibizumab and single administration of dexamethasone implant were similar till 3 months from baseline, but at 6 months, visual acuity gains were inferior with dexamethasone implant as compared to ranibizumab. Adverse effects were more common in the dexamethasone group. Patients with CRVO without macular edema or neovascularization should be followed up monthly for 6 months, following which follow-up intervals can be extended, but CRVO patients with macular edema and or neovascularization need to be followed up closely for a longer period of time. Thank you for listening.